Hello, my name is Matt Strelo from Stanford University, and in these lectures we're going to talk about the evaluation of an ECG. We're going to focus on having a systematic approach to looking at ECGs, or electrocardiograms. And this is our first part, so we're going to do an introduction to ECGs. Why is it important to be able to evaluate ECGs well as a healthcare provider? Well, if you practice in almost any setting, you'll eventually come across an ECG. If you're practicing in a busy emergency or urgent care setting, you can see an ECG every 3 to 5 minutes that someone is handing to you to evaluate. And you don't have much time to look at those ECGs. So you need a rapid approach that identifies the key findings on ECG so that you don't miss immediate life threats when you look at that ECG quickly. So let's get started with our introduction to ECGs. And we'll talk about the anatomy of a heartbeat briefly. So here's our heart, right? And if we do a diagram of the heart, it looks something like this, with our 4 chambers that we're all familiar with. We have the right atria, the left ventricle, and the right ventricle. And that's the physical structure of our heart. But what we're really looking at is the electrical pathway of the heart. When we talk about the electrical pathway of the heart, we talk about the highway that the electricity tends to travel. And it goes from the sinoatrial node to the AV or atrioventricular node, and then down the superhighways of the left bundle branch and the right bundle branch. And by following this pathway, it rapidly depolarizes the heart and allows a coordinated mechanical contraction. So let's start with atrial depolarization. So we know that the atrial depolarization starts at the SA node and travels down then to the AV node. This appears on our rhythm strip, or ECG, as a P wave. The P wave represents that depolarization of the atria. So it's starting at the SA node and traveling down to the AV node, and we see the P wave. The ventricular depolarization starts at our AV node and then travels down our superhighways, or our right and left bundle branches, rapidly depolarizing the ventricle. And this appears as a QRS on our ECG or rhythm strip. And the QRS then represents the depolarization of the ventricle. So it's going to start at the AV node and travel rapidly down our superhighways, the right and left bundle branch blocks, or bundle branches. The T wave on the ECG or rhythm strip represents the repolarization of the ventricle. So the anatomy of the heartbeat then is the electrical current starts at the SA node, travels down to the AV node, then rapidly down our superhighways of our right and left bundles, forming our P, our QRS complex, and our T wave. Now, what about the repolarization then of the atria? Well, we see the repolarization of the ventricle as a large T wave, but that's because it's a lot of muscle and there's no other electrical currents happening at that time. We don't see the repolarization of the atria because it's a very small amount of muscle tissue, and it occurs generally during the time period of the QRS complex. So it's a very small wave that's actually buried in the QRS complex. So you don't see the P wave or atrial repolarization. That's the anatomy of our heartbeat, right? So it starts at the SA node. The P wave is the depolarization of the atria. The QRS is the depolarization of the ventricle. And the T wave is the repolarization of the ventricle. So how do we pick this up, and what does it look like on an ECG? Well, on an ECG, we typically get a 12-lead ECG, and we have our limb leads and our precordial leads. So our precordial leads are V1 through V6. And what we do is most of these leads are placed on the left side of the chest where the majority of the heart resides. And you'll start though with V1 just to the right side of the sternum around the fourth intercostal space, and then progressively track V2, 3, 4, 5, and 6, wrapping it around to the mid-axillary line where you'll place V6. The limb leads have AVR placed on the right arm, AVL on the left, and then AVF placed on a lower extremity limb. And what you do then, once you've placed these leads, you will get a 12-lead ECG. And this is the traditional 12-lead ECG that we obtain, where we see leads 1, 2, and 3, AVR, AVL, and AVF. Those are all our limb leads. And then we see V1 through V6, which are our precordial leads. So they're looking closer at the heart. Unfortunately, these leads have a lot of tradition associated with their naming, and they don't really go together in the way that you might think. So lead 1 doesn't really correspond to a close part of the heart that lead 2 does. They're not next to each other. So we need to know how these anatomic lead groupings happen so we can look and evaluate the ECG appropriately. The anatomic lead groupings are the inferior leads, which look at the inferior part of the heart, okay? And a lot of the inferior part of the heart can be the part of the right ventricle as well. And that's lead 2, 3, and AVF. The anterior lead group, which is going to look at a lot of the left ventricle of the heart, and that's V1, V2, V3, and 4. Our lateral leads, which are V5 and 6, and they transition then into our high lateral leads, which are 1 and AVL. So if I'm looking at something and trying to figure out a damage pattern in the heart, and I see an evidence of injury in V6, I'm also going to look at V5 and lead 1 to see if they go together, and there's multiple leads looking at the same part of the heart suggesting damage. So it's really important to know your anatomic lead groupings that are shown here. So we're going to use the ECG that we obtained then to do a systematic approach to rapidly reviewing the ECG, looking for the critical findings that we need to know right away. And we're going to do a rate, and then look at the rhythm, the QRS complex, the ST segments, and then finally the T waves. And using a systematic approach, we should be able to evaluate an ECG after practice in about 30 seconds to 2 minutes without missing any significant major findings.